is your question? Right. So if you have read and understood, considering it communication skills session, kindly begin.
Okay. Hello, I am Dr. Saidur Rahman, one of the surgical doctor. May I confirm your name and age, please?
I'm Matthew. I'm 55 years of age.
Good.
Thank you. Nice to meet you. Today I've been asked to discuss you about some invitation that we arranged for you. Before discussion, please can I say that what you know so far about this?
Yeah, doctor, I have having this problem with my swallowing for last 6 months, and they have done a barium swallow, which showed some narrowing. Now they're saying that I have to go do some OGD scan. Can you please tell me what about it?
Okay, we plan for you the OGD. That means esophageal gastroenteroscopy. That in short we say that OGD, and it is a camera. Like we can introduce this camera through your mouth towards your food pipe, and to we go the upper part of the tummy and see this camera replace some image to that we can see on the TB scan. And if already very much slow, which identify some narrowing space in your food pipe, so we can dilate it this narrowing place, and also we can take some sample from this place, and we send it for some assessment analysis in the lab, and it will help
Okay,
us
doctor,
to
you are giving too much
find out.
information altogether. Please, can you give it in chunk? I'm not following you quite.
Okay, sure. We just
Thank you.
introduce this
So you told
camera.
about
Okay,
dilating. How are you gonna do this?
okay. This camera help us to dilate this area. We can identify this area already by barium swallow, and we can dilate it and see the what is the main causes that you're feeling this type of symptom.
Okay. So is it gonna be painful?
We use some sedation that so that you cannot feel some pain, but you feel sometimes drowsy at this time.
Okay. So is there anything else you want to tell me?
Okay, we all said that we use some sedation so that you feel drowsy, and you cannot go home. So you need to some assistant to pick up to your home.
Okay, doctor. So what are the risks associated with this procedure?
Okay, no procedure is without risks. There is some risks in this procedure, like during introduce of the camera, there is chances of broken your teeth, and also there is sometime there is chances of chest infection, and we take some sample. I say that, so there may be chance of some bleeding, and the most serious there is a risk is that there is chance of cutting your food pipe. Then we need to surgical operation in this case.
Okay, so you are saying that there is chance of perfor perforation of my gut?
Okay. There is a chance, but that means not it is occurs. and where our expert surgeon are doing this. So hopefully we can manage this.
How are you gonna manage this?
Our surgeon is experienced surgeon, and we regularly do this type of procedure. There's a little bit chance that can be happen, and if this occurs unluckily, then our surgeon can operate and repair it. But it is rare, Mr.
Okay. Okay. So can I eat my regular diet before doing this procedure, or do you suggest anything for me?
Okay, we give some instruction that you cannot take some food, and after procedure, we observe you after full recovery, and you can after that we give some instruction that you can take food.
I can take food before my procedure?
No. We give some preparation before the procedure, and after that, our consultant also consult with you. She gives some information, and then you can what to do before the surgery.
Hey, doctor, I'm having this dribbling of saliva through my mouth. What do you think the cause is?
Okay, it is occurs maybe due to narrowing of your food pipe, and that causes the saliva not go down. That causes you feel this type of problem.
Okay. Is that all you want to tell me?
Okay, do do you want to know anything about this?
Yes. So when are you gonna do this?
Sorry.
How long it will take to my biopsy report to come?
Okay. Approximately 2 weeks need to get the biopsy report. And we know you are tense about this. We will inform you when the report is available.
Okay, thank you, doctor.
Ask
Okay.
for alternative procedure.
Yes, can you please tell me any other alternatives apart from this?
Okay, there is some alternative procedure like CT scan, MRI, and with those procedure we can conclude the diagnosis. We need to some sample for histological analysis, some laboratory analysis. So procedure is better than those procedure. So I advise you please take your decision to do this procedure.
Okay, doctor. Thank you.
Okay. Thank you. If you want to know anything, I leave my number to the station. You don't hesitate. Please call me anytime.
Okay,
Yes,
sure.
and make sure
Okay, thank you.
patient signs the consent form. Still have 25
Okay.
seconds.
If you agree to do this procedure, please sign the consent paper. And can I summary what we discussed now?
Yes, please.
Okay, we discussed with you some procedure like OGD, and we discussed about the complication of this procedure, and we also inform you that you cannot go home alone, and you need to assistant, and our report will become around 2 weeks, and we will contact with you when report come. Are you now you can sign the documents and consent paper.
Okay.
All right.
Okay, thank you.
Time has gone. How was we supposed to end the consultation? One, okay, signing the consent form. Secondly, you have to confirm if patient has understood everything you have explained to the patient. So you were supposed to ask the patient to summarize so that you could evaluate how much patient has understood instead of you summarizing it for the patient. Right.
Okay.
And yeah, what is another word for dilatation? If you can tell me why OGD you want to do? What would be the easy term, easy word? In a
Enlargement
layman
of food
language.
pipe. Right?
Yeah, enlargement or widening or opening of a
widening.
yeah. So that you can
Yes,
use
widening.
another widening, because dilatation is like a medical terminology. Like we dilate, we know what dilatation is, layman people. Widening, or if there is some narrowing, okay, they understand. If there is narrowing, so they can widen it, or they can expand it or stretch it. So yeah, you can use these sort of layman words to make them understand. Right. And what was that you were telling about eating around the time of the OGD? Because you were going to give general anesthesia for it, so patient was not supposed to eat anything after midnight.
Yeah, at least
If-
6 hours.
yeah.
Sleep.
8 hours.
Yes.
If patient was supposed to go under examination in the morning, but if it was in afternoon, then before 8 a.m. patient can eat something light, not too heavy, light breakfast, but before 8 a.m. if procedure was later in the afternoon. So you had to make sure at what time patient was having procedure, and then you had to give advice about how are you going to prepare the patient for the procedure. Then there were two procedures you could have explained, like a spray and the other one, sedation.
Alternative procedure, MRI, CT scan, or
No.
any other thing?
Alternative procedure in this scenario was the same barium swallow, which was already done. So
Yes.
you could have said, since the alternative procedure, which we do normally, has already been done, so now the only option left with us, unfortunately, which is really painful and invasive, is only OGD. And in the advantage of doing this is that we can take a small piece, a small sample, which we can check in the laboratory to know exactly what is the reason, what is the cause behind your all this suffering and problem. So instead of like making or using too many medical words, you can make it simple, break it down. And and like this is, but we are getting there. It doesn't matter. Every day we'll practice and hopefully we'll get there.
Inshallah.
Definitely. And here is your question. Right. So if you have read and understood, considering a clinical examination station, kindly begin.
I will enter the room, I will wash my hands, greet the patients. Hello, I'm Dr. Muhammad, the surgical doctor. Today I have been asked to examine your chest, which will include looking, feeling, and listening. Are you okay with that?
Yes.
Okay, I will reposition the patients at 45 degrees. I will expose the
You
abdomen.
request
Yes.
the patient to expose. Yes.
Yes. After that, I will start by general inspection at the end of the couch.
You forgot to confirm the name and the age. 57 years old Smith. Yes, now continue.
Yes. After that, I will start by general inspection at the end of the couch,
Yes.
looking for any oxygen connected to the patient, looking for any bedside drugs, and also will comment for any central cyanosis, any chest deformity or surgical scar. Also, I would like to count the respiratory rate. After that, I'll start by the local inspection of the hand. Can you stretch out your hand for me?
Yes.
Looking for any stigmata of the respiratory disease, any peripheral cyanosis, and also tar staining. Can you put your finger like this for me, please?
Yes.
Looking for any clubbing, and also can you stretch your hand like this?
Okay.
I would like to assess for tremor and astraxis. Then I would like to assess the radial of the rate rhythm and character, and also radial delay. After that, I would like to inspect for the neck and dilated vein, and also like to assess the JVB. Do you have any pain in your tummy?
No.
I will press at the right hypochondrium area. Then I would like to assess the eye for any color. Also, after, can you stick out your tongue for me?
Yes.
Looking for any central cyanosis and also oral hygiene and also any dehydrations. After that, I would like to palpate for the trachea, if it is central or deviated. Then after that, I would like to inspect for the pericardium, looking for any surgical scars, any dilated veins. Can you raise your armpit for me, please? Looking for
Yes.
any striatal scar. After that, I would like to palpate for the locate the apex. I would put my palm on the chest of the patient, and with the other finger, I would locate the apex of the heart. After that, I would like to do the palpation. I will start by the chest expansions at 3 river. I would like by the costal margin and the nipple and between them. After that, I would like to percuss. Do you have any pain?
No.
I will tap at the supraclavicular first, and then after the infraclavicular, and then anterior and the lateral at each intercostal space. Then I would like to auscultate. First, I would auscultate for any sound breathing, and would like to comment also about air equally, if it is inter-equal entry. Also in the same area, supraclavicular, infraclavicular, and anterior and lateral intercostal space. Also, after that, I would like to assess for the vocal resonance. Can you say 99 for me, please?
Yes.
Yes. At the
99.
supraclavicular and infraclavicular and anterolateral at each point of this. After that, I would like to also do the same at the back, but before that, I would like to assess for the lymph node enlargement, submental and submandibular and superficial and deep cervical lymph node, and also pre and post auricular. I will comment also if any dilated vein, surgical scars. Also, I will do the chest expansion. After that, also the auscultate and also do the focal resonance. Also, I'd like to do this assess if there's any sacral edema and also any basal crepitations. After that, I would like to assess the lower limb, looking for any edema and also any deep calf vein if there's any skin change or pain all ulcer. I would like to complete my examination by examining the cardiovascular system. Thank you so much.
Okay. Can you present your examination? You still had 50 seconds, but okay, continue.
Okay. Today I've been examined 57 years old male who's non-hypertensive and also smoker. On general inspection, there is no oxygen connected to the patient. There is central cyanosis, and there is no surgical scars, no deformity. On the inspection of the hand, there is no astraxis, and there is clubbing. The radial pulse rate about 60.
Okay.
There is no dilated veins, no pallor, no
Heart
no
rate
done
was
inspected.
normal. Okay. Can you
Yes.
please tell me what are your differential diagnosis?
My main differential diagnosis is COPD, and
Okay.
also it could be due to asthma.
Acute exacerbation of COPD, you want to say? Okay. And what
Yes.
else?
Patient could be asthmatic.
Okay. And third one?
Yes, could be due to chest infections,
All right.
pneumonia.
Okay. How would you confirm your diagnosis? What investigations would you ask for?
Was asked for the routine investigations and CBC urologic university, and also would like to do chest X-ray and ABT and also
Yeah.
spirometer
Yeah. And respiratory
and
function
expiratory
test.
function test.
All right.
Yes.
Okay. And maybe ABGs as well. Okay. What are the management alternatives that you can offer to the patient?
Okay.
Or how would you reduce the risk in this patient for COPD to undergo, because this patient
Yes,
is
if patient is
smoker and
going for
hypertensive as well?
if patient is going for surgery, then I would like to do the regular. I will contact the GP to optimize his medication
Yeah.
and also control the infections and also involve physiotherapist before and after the surgery. And also would like to inform the consultant, the anesthetist, and the general surgeon.
And HDU?
Yes, I
Higher
would like to
dependency
book an
unit.
HDU post-operatively.
Yes.
And also, this patient should have regional anesthesia rather
Yes.
than general.
Yes. And open surgery rather than laparoscopic. Because
Yes, because of the retention of carbon dioxide.
to pneumoperitoneum. Okay, good. Any other advice? If patient has
Yes,
any infection?
stopping smoking
Okay,
and regular
good.
exercise.
Yes, and if patient has any infection, that should be managed and treated before you'll go for the operation. All right, good. One little query, I think it was all right, but then how systematically should we go for this kind of examination? Because once you started off with the journal examination instead of the inspection of the chest. So, all right, first you did the general examination. You looked for the hand and the tongue and everything. And then afterwards, when you position the patient and you wanted to do the inspection of the chest, only then maybe you can request the patient to sit back at 45 degrees and then patient can take off the gown rather than in the beginning, like right from the beginning. And then here, since you had the time, I could not understand. Maybe once I think you said you'll examine the right iliac fossa. I'm not sure I heard it right.
I said I will press on the right hypochondrium area
Hypochondrium.
to assess
Okay, I thought you said
GFAP.
right iliac fossa. That's
Yeah.
why I was thinking, why would you
No.
mix the two examinations? Okay, must have been my ears. Okay, good. Thank you. Thank you. And here is your timer and your question. Right. So if you have read and understood, considering that history taking station, kindly begin.
Hello, my name is Dr. Mahmood. I'm one of the exam candidates. May I confirm your name and age, please?
Yes, I'm Smith, 56-year-old male.
Nice to meet you, Mr. Smith. Today we asked to ask you a few questions regarding your condition. Will that be okay?
Yeah, sure.
How can I help you today?
Doctor, for past couple of days, 5 weeks, I'm thinking I'm passing blood while I'm passing my urine.
Mhm.
I'm feeling
I'm
very
really
much
sorry.
exhausted these days.
Okay. So I'm really sorry to hear that. Could you tell me when you do notice this for the first time?
Yeah, it happened just 5 weeks back when I noticed that there is reddishness of my urine.
Mhm.
I think the blood is coming while I'm passing urine. I'm really worried
Okay.
about it, doctor.
Okay, I'm really sorry. So is this start suddenly or gradually?
I I thought it was started gradually, but I'm noticing it now only.
Okay. Okay. So is this present when you're passing urine?
Yeah, doctor. When I go to washroom and when I start passing urine,
Mhm.
I feel that time some reddish color urine is coming out.
Okay. Have you eaten beetroot recently?
No, doctor.
Okay. Is there any condition which makes better this problem?
No, doctor.
Is there a condition which make worse this problem?
No, doctor.
Okay. Is this blood is come in goes or worse than before?
Uh, Doctor, I think the episodes has increased now. Earlier it was less. I think over a period of 5 weeks, it has increased. Now
Okay.
with every whenever I go to washroom, I find that my urine is red only.
Okay. So is this blood is present at the start of the urination or at the end or throughout?
I haven't noticed that. I think it's present throughout.
Okay. Is there any clots in the blood?
No, doctor.
Okay. Have you noticed any unintentional loss?
Yeah, I feel exhausted these days. I haven't measured that I have lost weight, but I find my clothes are loose these days.
Okay, I'm really sorry to hear that. How is your appetite?
I don't want to eat these days, doctor. I'm not feeling to eat.
Okay. Do you have any pain in your tummy or your groin area?
No, doctor.
Okay. Do you feel any pain when you're passing urine?
No,
Okay. Have you been feverish?
no.
Okay. For how many times you go to washroom to pass urine during the daytime?
Doctor, you as usual. I go to washroom 3-4 times a day.
Okay. Okay. Have you had any trauma to your tummy or your groin area?
Sorry.
Have
Lower
you had any
abdomen.
trauma to your tummy or groin
No,
area?
no, doctor. No, doctor. No trauma, doctor.
Okay. Is there any other orifices which bleeding coming from that?
What is orifices, doctor?
Openings.
Opening.
No, doctor.
Okay. Okay. For how many time you wake up during the night time to pass urine?
Uh, Doctor, these days, I'm getting quite often during the night, and
Okay.
I felt like I
Okay.
felt
So
that my urine urine stream is also very weak these days.
Okay, I'm so sorry to hear that. So, have you noticed any prolonged dribbling at the end?
No, doctor.
Okay. So, do you have any other medical condition?
I'm Dr. Hypertensive, but my GP said it is controlled with the medication.
Okay. Have you had any other? Have you had any surgery before?
No, doctor.
Okay. Do you take medication?
I told you, doctor, I took medicine for my BP, blood pressure.
Can you please name me the medicine?
I don't know the name of that medication, doctor.
Okay. Do you have any allergy against medication?
No, doctor.
Okay. So can I ask some personal question?
Yeah, sure, doctor.
Okay. What's your job?
I work in a factory.
Okay. So who is living with you?
Can you summarize
live
your
alone.
history now?
Okay. So okay. This is a 55-year-old male Smith, which presented with painless blood from last 5 weeks, and also he has a growing pain from last 2 days, and he is a known case of the hypertension, takes some medication, and then also he has some weak stream and prolonged dribbling at the end of the urination. He also lost weight, but he doesn't know how many. He also worked in the factory, dye factory.
Yes. So what are your differential
Yes,
diagnoses
madam.
for this patient?
My differential diagnosis, first of all, I will rule out Beirut CA, and I will also keep in mind UTI and PPH, and also trauma to the groin area and a bleeding tendency.
Okay. How do you suggest to manage this patient?
First of all, I will go for baseline, full blood count, and also blood plus screening, and also prostatic specific antigen. I will also advise urine dipstick to confirm hematuria and assess infection, and for cytology. And I will also advise ultrasound and CT scan.
What are the treatment alternatives that can be offered to the patient?
It's depend on the tumor grading and staging. For the, if for surgery, I will go for a URBT and also radical cystectomy. If the tumor is resectable as given meds, then I will go for chemotherapy, radiotherapy, and immunotherapy.
If time would have allowed you, how would you have completed your history?
Yes, madam, could you please repeat?
If time would have allowed you, how would you have completed your history?
Yes.
What was left behind?
So I will go, yes, but I will go for eyes, idea
Yes.
concern and expectation, and I will also take some question regarding to review questions. System.
Yes, good.
Yes.
So when I asked you or requested you to summarize your history, if you begin that if time
Yes,
would have
ma'am.
allowed me, I would have done the ICE and the review questions.
Okay.
And then you can present that today you took the history of Mr. Smith, etc. So this will give you the points that you have missed. Good.
Okay, ma'am.
Thank you. Yes, you started your timer and here is your question. No turning around papers, please. Put them aside with your brain, whatever you know. please.
Okay.
Thank you. No cheating. Okay. So if you have read and understood, considering it surgical pathologist patient, kindly tell me what is your differential diagnosis after you have read the stem?
It's malignant melanoma, which with METs.
Okay, this is number 1 diagnosis. What would be your number 2 and 3? What else would you consider?
I also consider squamous cell carcinoma
Very good. And
keratoacanthoma
okay,
or basal cell carcinoma.
yes, or lymphoma. Okay, very good. How would you confirm your diagnosis? If it has to be malignant melanoma with metastasis, how would you confirm it? What investigations? Yes.
I will take excisional biopsy from the upper arm mole and
Yes.
making a staging or take if any lymph node involved. I will take fine needle aspiration or
Yes.
tissue biopsy.
Very good. Okay, can you please tell me how would you differentiate it from squamous cell carcinoma?
Malignant melanoma get from the lower layer of epiderm, and the
Yes.
squamous cell carcinoma get from the upper layer of epiderm and the
Okay.
middle layer.
This is one difference. More.
Second, the malignant melanoma come from any part of the body, and the squamous cell come from especially in sun exposure sites.
Very good. Yes. Give me one more reason, then we'll move on.
Malignant melanoma, it's a blackish in color, and squamous cell is may ulcerate or
Good.
non-black.
Good. Okay. Can you please tell me what are the types of malignant melanoma that you know of?
There's many type of malignant
Very
melanoma,
good.
such as lentigo
Yes.
or spreading type,
Yes.
or acral type, or nodular type, or desmoplastic type, or amyloidotic melanoma.
Very good. Can you please tell me what is epithelioid melanoma?
Oh, again, please.
Epithelioid melanoma?
Epithelid melanoma. Bus, please.
Okay. Right. Can you please help me and read this image? What are you looking at? What kind of image is this?
I'm look to a mole on the skin, blackish in color.
Yes.
With keratin, with irregular edges.
Okay.
And surface.
And surface and crest-like, okay, appearance. All right, good. Can you please tell me what are the types of skin conditions which are associated with melanoma?
Type of skin.
Yes. What are the skin conditions which are associated with melanoma?
Telangiectasia.
Xeroderma pigmentosum. Yes, and albinism. Very good. And
albinism, bits bright skin type 1 or
dysplastic nevus. Very good. Okay, can you please tell me what are the other risk factors which are associated with malignant melanoma?
Tendency to freckle or sun exposure or immune compromised.
Very good. Okay, if you have confirmed your diagnosis and this happens to be malignant melanoma, what are the management options that can be offered to the patient?
I will go to excision with safety margin, and if there is lymph node involvement, I would make a block dissection of lymph node and the radiotherapy.
Very good. Can you please tell me how would you determine the margins for malignant melanoma? If lesion is more than, yes, more than 1 millimeter, or if lesion is less than 1 millimeter, how would you do it? How would you decide?
According to Breslow thickness
Very good.
score, if more than 1 millimeter, I will excise with 3 centimeter margin, safety margin, or if less than 1 millimeter, I will excise with 2 centimeter margin.
Very good. Can you please tell me the difference between Breslow thickness and Clark's level?
Breslow thickness is a measurement of thickness of mole from the stratum granulosum to the deepest part of the epiderm. And Clark, it's an invasion of malignant melanoma under epiderm.
Very good. Okay. Right. After you have operated on the patient, what are the measures that you should advise to the patient to keep in his or her mind?
Again, please.
After you have operated or excised the lesion, what are the information that you'll give to the patient or you'll keep in your mind?
That it is a malignant, it is a cancer, and it may be recurrence, and we should follow
yes.
up for knowing the recurrence if occurred again.
I wanted you to focus on hypercoagulable state because it's malignant. It's cancer, so that's why. Okay, can you please tell me what are the genes which are responsible or which are involved in malignant melanoma? Can you name few?
We can. I think. Pass, please.
Okay, pass. Can you name few poor prognostic factors for malignant melanoma?
Sickness of malignant melanoma and the deep and the invasion and the ulceration and the lymphovascular invasion and the distant metastasis.
Yes. Male gender, old age. In addition to this,
in male
gender and old age as well. Okay.
Yes.
Right. If since this patient is suffering from, all right, time has gone as well. Yes, I was going to ask you because this patient has distant metastasis as well, maybe. So how would you? What management can you suggest for this patient? Because patient is having difficulty with breathing and their abdominal pain and their hardened plaque.
For this patient, I will make a staging by CT, and we will. I will give him a radiotherapy.
Discuss in MDT, and then you'll suggest. Okay. So long palliative. Good. Thank you.
Thanks.
Thank you. Starting your timer, and here is your question. Right. So if you have read and understood, considering the communication skills patient, kindly begin.
Hello. Hello. Good
Yes.
morning. I am Dr. Kuldeep, one of the surgical candidate. I have been told that you are you have some concern regarding your stopping of your drug before the surgery. Um, I am here to help you. I am here to resolve your apprehension. Is it okay with you to talk to me?
Yes. Just go ahead.
Can you just let me know what you know so far about this medicine?
Yeah, I'm John. I'm 65-year-old, and I'm having so many problems. I'm having this recurrent problem with my groin area, and doctor, I can't say, And I also have heart surgery. They replaced one of my valves. I'm on a blood thinner, so now they're saying that I have to stop my blood thinners before my operation. I'm really worried about it.
I absolutely knowing that, sir. I am here to help you. I will definitely help you to resolve your anxiousness and apprehension. Let me explain you what this drug is. Sir, this drug, as you already told me, you underwent a surgery. Your valves are replaced. So this drug is a blood thinner named as warfarin. It helps to thin out your blood so that don't there is no clotting, no clot formation in your blood, so that you doesn't have any symptoms. But the issue is that, sir, we have to stop this drug because you are planned for a surgery. Because this drug, as I've drawn on this paper also, this drug has a action which take this drug has a long duration of action. If we don't stop this drug before few days before the surgery, then you might bleed a lot while during surgery. Are you getting me, sir, what I am telling you?
Yeah, yes. How long before I have to stop?
Sir, as this drug has a duration of it takes almost 5 days, so we need to stop it 5 days before your surgery. But you don't worry, sir, we will start you on injections which will help you to make your blood thin so that you don't there will be no formation of clot in your blood. Is it okay with you, sir?
Yeah. So you're saying that my earlier drug will cause bleeding during my operation, but the later injection will not cause the same problem too?
Sir, because the action which is the drug which the action which the drug is and the action which the injection will cause have a similar effect, sir. That's why we are
Okay.
starting you stopping the drug and starting you the injections.
So what advantage are you gonna get from it?
Sorry, sir.
What advantage are you gonna get from it?
Sir, because the injection are having a shorter duration of action, sir, as
Okay.
compared to the drug warfarin, as I've drawn on this paper, it has a long duration of action. It will take almost 5 days to act upon. Injection just 12 hours. It takes just few hours to act, and we just need to stop these injections just 12 hours before the surgery, and it will not cause any major issues during your surgery. Is it okay with you,
Okay.
sir?
Yes. Yes.
Sir, you have any issues, sir? Any more
Yeah.
queries, sir?
So are you gonna stop this drug? I mean medicine for whole life, or are you gonna stop it and again you use
Sir,
my previous drug?
yes, sir. I will explain you this in detail, sir. So we will stop as I have drawn on this paper, sir. As we will stop your warfarin, which you are taking 5 days before the surgery. Then we will start you on the injection that is called low molecular weight heparin, and we will start this drug. So with these injections, we will stop this injection 12 hour before the surgery, and as soon as you come out of from the surgery and you are able to or take the medicine orally, we will start this tablet and we will continue with the injection until we have a good response in good response response in not forming your clots, then you can resume your drug and will stop giving you the injections. Is this fine with you, sir?
Yeah. So when are you going to start with my injection? When are you going to stop this warfarin and start this injection?
Sir, we will stop this warfarin 5 days before the surgery, sir. And I want that you remain in the hospital so that we monitor you better and we will start you the injection. It will take 5 days before surgery, sir.
Okay. But can I not give it in my home?
Sir,
because staying in hospital, it's very troublesome.
Sir, I totally understand, sir. I totally understand your concern, but we want your safety first, sir. We want that you don't have any issues at your home. That's why we want to monitor we want to monitor that your blood doesn't get clot and doesn't have any issues, so that we want to give this injection in the hospital itself, sir.
Can you please arrange it at my home?
Sir, we can talk to our consultant. I will talk to my consultant, but in favor of your best interest, I want that you get admitted and we stop the warfarin and we give you the injection, because otherwise it can lead to serious side effects. For example, you can bleed at home, you can have any issues with your mechanical valves, so that we want that you stay in the hospital, we take care of you, sir. Anything else you to ask, sir? Any questions, sir? So if there is if I helped you answering all your doubts, as well as I resolve your queries, and
can I ask you one more question?
Yes, sir. Sure, sir. I'm here to help you. Tell me.
Yeah, well, I was taking my warfarin. The doctors asked me to do a test called PTI. So
yes,
do
sir.
you think I'll have to do this while I'm taking this injection also?
Sir, for this injection, we need to get some tests done, which are similar to that. We will let you know that they are called APGT, sir. That or prothrombin time. They are activated prothrombin that are different from PT, which you are doing, sir.
So what is the amount I have to keep? Is there any specific value? Because during INR, what I have done, I was doing earlier, my cardiac surgeon told me that I have to keep it around 2 to 3. Is there any specific value of it?
Sir, we will titrate your medication according to your requirements, sir, and we will discuss with the medics regarding the same, sir.
Okay. Do I have to stop my diazepam?
So let me summarize what we have gone through, sir. As you are posted for elective inguinal surgery repair, and you are a case of mechanical heart valve. So we need to stop your warfarin. We will stop your warfarin from the operation, and during this period, you will be receiving an injection called heparin, which will be stopped after 12 hours before the surgery, and will be resumed after 12 hours before the surgery, and warfarin will be resumed after the surgery as soon as you can orally take, and there will be no further risk of bleeding. And heparin will be stopped when the lab test indicates that the warfarin can resume its action effectively. And we are here to help you, sir. If there will be any query, any question at any time, we are here to help you, and we will dive you a hand at any time.
Thank you very much, doctor.
Yes, tell the patient about the diazepam. What do you advise about the diazepam to the patient?
There is no need to stop your anti-anxiolytic drug. You can take it with a sip of water. And
thank you.
Thank you.
Good. Thank you. Yes. Right. Give feedback first, please. Opening question.
Yeah,
was
you have
very
covered
good.
everything.
Yes. Almost. but we'll still make or pick out the wrong answer. Yes, the opening question was very good. How you presented, how you started off the conversation, exactly the way it was very good. You, just like Dr. HK said, covered almost everything. But one question a patient was asking you again and again, because patient was living alone and patient could not stop and
Yeah, I
start.
was also coming to that.
Yes. So
Actually,
how
ma'am,
your
I was
take should have been on that?
actually I thought of answering that we will discuss with your. I can write a letter to your GP and that GP can give
Yes,
you in
yes.
home visit. But I don't know about the guidelines in UK regarding this
Of
injection,
course
because
you can.
in
Nurses.
India, ma'am,
No,
in
we
India we
have
give
to
to
erase India from mind. You have to bring UK in your mind. So,
Dr.
but
Kuldeep,
Ma'am,
we used to do that. We used to do that. Like we will arrange nurses, home care
yes,
nurses to you
home care
for you.
nurses. And I'll talk with the social services and we'll see if we can arrange nursing manager who can, with the help of your GP, can take care of you at home. Because once you
actually,
said, yeah, but in this
actually, ma'am,
one,
that's why
yes,
on the safer side, that's why I did. I will talk to my consultant. I will let you
no,
know if we can do it. Okay,
consultant
ma'am. I
has
will.
sent you to talk to the patient. If you
Okay, ma'am.
involve consultant in everything, that means they'll think this is like a very, this will give you a very bad impression, like that you cannot manage things yourself. You'll drag your boss for everything. So here you have to manage the patient. If patient is insisting, no, I cannot be hospitalized. I need you to arrange it for me at home. Then you can offer this. But then you can say, I would still recommend that you get hospitalized. But if you insist, then I'll get it arranged like this. Then this is the
Okay, ma'am.
yeah. And then you don't have to talk about those other tests that you have to do. Patient will just only ask you why to stop, then when to stop, okay, why this injection will be given, and then when to take my medication again. And in the beginning, like patient will be a lot of anxious and frustrated that I have been told never to stop this medication. I can stop breathing, but I cannot stop taking this medication, warfarin. This kind of image or etc. will be given. And here patient exclusively told you that I cannot see. Patient will be wearing
Yes, ma'am.
sunglasses. So how would you ask the patient, or how would you respond? Can anyone else answer? Yeah. So I'm starting your timer. So read and then tell me, I'll move on. Yes, not much information on this page.
Yes, next please.
Yes, yes. Yes, next.
Wait a minute.
Take your time, no problem.
Yes, ma'am. Next
Yes,
slide,
yes.
please.
Okay.
Ma'am, can I check? Is that left or right leg?
Yes. Right.
Right. Okay, I think I'm
Yes.
ready.
We can begin. Right. So if you have read and understood, considering good communication skills station, kindly begin.
Hello.
Hello.
So, I'm one of the surgery doctors here in the surgical department. I'm called to talk to a trauma consultant on call today. Am I talking to a trauma consultant right now?
Yeah.
Okay.
Dr. Man.
Yeah, Mr. Man. Now I'm going to inform a 20-year-old motorbike rider who is likely to have right limb ischemia, who is complaining of corpuscular extremity and worsening pain due to a road traffic accident. Yeah.
Doctor, why? Stop, doctor. Why are you calling me this odd hours?
Because he's likely to have limb ischemia, which is a critical condition, might need surgery later as soon as possible. Yep. He has been hit and run and admitted to surgical call. Now his GCR is 15. He is hemodynamically stable. On examination, he has open and contaminated tibial fibular fracture on the right side, on the left, sorry, I'm confused, on the right side, on the right leg, and abdomen indicated left flank aberration with abdomen distension and tenderness. And on the investigations, X-ray indicated open tibia fracture, and ultrasound showed free fluid in paracolic gather.
Okay. Do you feel it is you give first priority to your abdomen or to the leg?
My first priority problem would be for this patient would be limb ischemia, possible limb ischemia on his right leg.
What are the signs of doctor? What are the signs of limb ischemia which have you seen?
The patient has been complaining of worsening pain and corpuscular extremity has been reported by the nurse.
Okay. So, what about the free fluid in the abdomen, doctor?
Pardon?
What about the free fluid in the abdomen?
Free fluid in the abdomen are likely to be due to perforation or bleeding from an internal organ such as liver or spleen. But he is hemodynamically stable right now. Although he has abdomen distension on the left flank, abrasion on the left flank with abdominal distension and tenderness, he is hemodynamically stable.
Okay. And what about the cause? What are the causes of pulseless foot, doctor? You mentioned there is no pulse on the right side,
Yes.
right? And what are the causes? What do you think the cause is?
It could be due to the disruption of the proximal femoral artery due to the fracture.
Doctor, you said it's fracture of the tibia and the fibula. You are saying femoral
Oh,
artery?
sorry. It could be due to tibia artery or popliteal artery.
Think.
Okay.
Think.
Okay. Anything else, doctor?
It could also be due to intra compartment pressure.
Yes, compartment syndrome.
Okay. What are the signs of compartment syndrome, doctor?
The patient will present with cold, pulseless, or increasing pain out of proportion, and then in color, apparently cold. Yes.
What is the status of his cervical spine, doctor?
I don't have any information about his spine, Mr. Mann. I'll have a look at it and try to report you right away after the call.
Okay. Is the patient dehydrated, doctor?
Since he is hemodynamically stable, I assume that he is hydrated, but I will try to assess the hydration status after this call.
Doctor, there is one investigation missing in the whole summary which you have given to me. Can you tell me which investigation which help us to document whether the distal pulses are there or not? Can you tell me?
To get the pulse, to assess the pulse, ABPI or Doppler ultrasound will be required, but I haven't done it yet. If you require that investigation result, I will try to get it.
Okay. So what are your plan of action, doctor?
My plan of action will be try to stabilize fracture, shift to the trauma ward, and get repair the artery.
So whom you involved in the case, doctor? Have you informed anybody else also?
Oh,
or just me only?
Well, I haven't been told that they haven't called anyone yet. So I will try to call all the necessary doctors, including orthopedic surgeon, vascular surgeon, cosmetic surgeon, and also I will also urge the general surgeon, because if in case his abdomen condition worsened, he might need a laparotomy.
But doctor, you just have a ultrasound fast, which told you the free fluid. Have you done any CT to rule out where is the perforation? Have you done that?
I don't have any information about CT. I will ask the nurse if CT has been done. Report you after that.
Okay. Will you order CT abdomen, pelvis?
Yes, it will be necessary.
Okay. Okay.
Is there anything to add or to give any advice to me, Dr. Mann?
Yeah, I just want that you just reduce and immobilize the spine.
Yes.
Meanwhile, unless you screen the spine, clear the spine, and get a CT abdomen, pelvis, and CT head and brain.
Yes.
And I will then we take the patient for the emergency surgery, because it looks like a vascular injury as per your examination.
Yes, ma'am. Sorry. Yes, Mr. Mann. Yes.
So you just inform the ITU registrar as well as the on-call anesthetic.
Yes, I will try to call the
patient.
anesthetic and OT team as well. Yes, thank you, Mr. Mann.
Did you discuss how will you fix the fracture?
No.
No, ma'am.
It will be open reduction and internal fixation.
Okay. And
No,
what
no.
did you do
See,
for the wound and
the
department? Yes.
Oh yeah,
doctor, actually, the open tibial fracture is with a gross soilage. So you
Yes.
don't do internal fixation. You can't do the internal fixation.
oh
in
yeah,
this.
yes,
You have,
yes,
and you are repairing the vessel. You are repairing the
Yeah.
vessel. You have to put external fixator in this.
yeah, yeah,
It's not an internal fixation.
yeah,
Think always, yes.
yeah.
And the wound, what would you
To
do
be
with the
cleaned
wound?
thoroughly.
Yes, very good. Okay.
Yeah, I forgot that.
Yeah, it wasn't that good. According to me.
Yeah.
Can I ask one question?
Yes, sure.
Would you do the orthopedic surgery first or the vascular surgery first?
Very good question.
Can I answer this, Dr. HK?
No, doctor.
Yep.
First,
Okay,
Dr.
okay.
Cynthia, and if she cannot answer, then Dr. Kuldeep, please. She has to learn as well. Yes, please, Dr.
Surgery first, I think, and maybe both at the same time, vascular and orthopedic.
One investigation you forgot
Yep.
to mention. There were lower limb angiogram as well. Pulseless extremity. First, you'll take care of the vascular. Oh, sorry, Dr. Kuldeep, you answer first.
See, we have to fix the fracture first, then we need to repair the vessel, because we can't repair the vessel without fixing the fracture, because it will be
Yeah,
again
true.
liable for injury.
Yes, and the damage which has happened, it has happened. It's not going to recover. Vascular, I mean. So that's
Yes.
why orthopedic first. Good. Good, thank you.